Hi, I'm Brad Power, and this is the Cancer Patient Lab, and we're honored today to have with us Dr. Chris Apfel and Cliff Reid. They're going to be talking about the areas of evidence and the spectrum, decision making, the standard of care, how that all fits, how that influences decisions that patients and doctors may make, and how you can sort of tease away maybe some of the simple thinking that the standard of care must be the best because it's um, the one that everybody works from. It's the standard, it's the guidelines, and yet it's perhaps not as perfect as we might think. So we'll get into that, I suspect. And Chris will be talking about the range of evidence and the different ways of evidence. He has a background, for those of you who don't know, having written many articles and being really having a statistical view of what qualifies as evidence, how you can design randomized clinical trials, these sorts of things. So he's a perfect person to be talking about it and translating that into the implications for patients and caregivers. Cliff Reid is CEO of Cancer Commons. He's been working to build out um, something he'll introduce called PCCN. It's at one level, and again, he'll do a better job of describing it than I can, but it's a N of one registry that allows people to get what's best for them on a personalized basis and then track what happens in an observational registry. So he'll be talking about that. And these things are related because what's best is probably N of one, and then but it's not really part of the current paradigm, which is based on the guidelines, which are based on population averages, not necessarily personalized solutions for an individual patient, which again, I'm sure we'll get into. So with that, I'll turn it over to Dr. Chris Apfel, who is, I hope all of you know, but he's co-founder and CEO of Sage Medic.
Great. Can you all hear me well?
Yes.
And can you see my screen?
Yes.
Perfect.
And
Great.
your image, your head is in front of the slide. I've never seen this before on Zoom. You must be doing something different, or else Zoom has changed. I don't know.
No, so you can actually select on whether you just want to have the slide, you want to have yourself and the slide next to one another, or yourself in the slides. And I was playing around with it. I actually don't see it on my end.
Okay. Well, hopefully your head
All
won't
right.
cover up any important information on the slide.
I think, yeah, it's if I don't, I can also speak, and I think the most of the information is actually by me speaking to what I'm presenting here. And the slides are only a little bit of supporting information or whatever I'm presenting here. And to me, what's important is if a cancer patient is running out of options and standard of care is failing the cancer patient, that the patient has the opportunity or the ability to think about, is there anything we can do beyond standard of care? Because standard of care does not necessarily mean the best possible care. And and so what I thought would be a good idea is to give a little overview on what standard of care is, what the definitions are. And so I've put my head down this morning and tried to jot something down to bring clarity into this because it's not trivial. And when we talk about terms that are very commonly used, and we all have slightly different perspectives on what it means and what the implications are, then there could be misunderstandings. And so really understanding what it means or what we believe it means is important. So in general, this is a generally accepted level and type of care based on current scientific evidence, clinical guidelines, which should also be based on scientific evidence to the extent possible, and professional consensus. So that basically defines standard of care, and it has different implications for different people. Here, I'm more focusing on the implications for an oncologist, because to standard of care, reimbursement and billing is tied. And if you deviate from it, you can get into challenges. You sometimes you need prior authorization, and then there are these so-called payer-approved pathways that very few people are aware of. So they are often pre-approved, And if you comply with them to, let's say, more than 80% of your patients, then you get an extra bonus of, let's say, $300 per patient, no matter what. If you don't, and then you don't get it. And so there are a number of incentives to make sure the oncologist applies the payer-approved pathways. And then there is, of course, regulatory and documentation burden from Medicare, etc. Hospital credentialing and peer reviewed is dependent on practicing according to standard of care. Um, and and this is also used as a benchmark for malpractice litigation if the outcome is unfavorable. And in the field of oncologists, it actually does happen from time to time. And so oncologists are um, very conscientious about their workflow to make sure this is within the pathways. And with the high caseload they have, the limited time they have for patients, that's actually what holds their feet to the fire or what kind of restricts them in the liberty to really look at the individual patient. And so the standard of care functions basically as a multi-layer control system: legal, financial, institutional, operational. And so that strongly channels what oncologists can do and channels them towards these guideline conforming practices. Um, and yes, we still have individual judgment, but the surrounding system makes deviation increasingly costly and difficult. And I think we that's an important part to understand. Where does the other side come from? I mean, all oncologists, I would say, have gone through all this training to really help cancer patients and have put a lot of work and effort and education into this. But then in many ways are sometimes also restricted by the system itself in which they have to operate. Now, there is also the argument of evidence-based medicine, and that's actually a very interesting phenomenon. And I looked this up. It was actually from Sackett, not Flaherty. It's actually the conscientious, explicit, and judicious use of best available current evidence in making decisions about the care of an individual patient. So, best available research evidence, then the clinical expertise or the clinical judgment, because very often we don't have research data on it, and including the patient values and preferences. And this is, in a way, this goes into Cliff's N of one approach on what Cancer Commons tries to accomplish. That really one can actually understand what's the best available evidence or research evidence, and not just the guidelines, and how can one actually consider this with the clinical expertise and the patient's values so that the individual patients, N of one, is actually treated. When it comes to evidence-based medicine, I have recently got a slide from one of our friends that actually put the guidelines on the top of the EBM pyramid, which I said, that's not right. And and I found a slide or a graph where it actually puts clinical practice guidelines and health technology assessment at the top. So he hasn't pulled it out of thin air, and that's actually, I think, the concept that is like that one would like to believe. But there is some reasoning and some rationale behind it, because that's actually what the Cochrane collaboration really started, and they realized that there are different levels of evidence, and evidence is not a binary factor. It's actually there is a continuum in terms of evidence, and it starts with expert opinion or case reports and case series. They're basically at the lowest bottom of evidence, and then when you look into systematically at data like retrospective, prospective cohort studies, or controlled clinical trials, or randomized controlled trials, these different levels, what they do is they reduce biases from the data so that the conclusion on those data is more likely to be true. And and ultimately, you would like to have a systematic review or meta-analysis of randomized controlled trials. Doesn't mean that you can't do a systematic review on all the other cases or other material. And you can also do a meta-analysis on cohort studies, also in the diagnostic field. But in principle, when people do a meta-analysis, a systematic review and meta-analysis, it's usually based on randomized controlled trials. And because they aggregate this evidence in a quantitative manner, they are basically at the top of the evidence level. Now, what's interesting here is the clinical practice guidelines with the health technology assessment, because here it's not just evidence that's taken into consideration. There are many other things that are taken into consideration. And another thing before I go on is this pyramid with randomized controlled trials, that this really works, is a pyramid that is appropriate for interventions. So either drugs or surgeries. One person gets operated, the other one doesn't. One gets the drugs, the other one gets placebo. That provides a very high level of evidence. But when we talk about diagnostics, that's often not appropriate. If you have a broken leg and the surgeon says, I want an x-ray before I operate on you, there is no randomized controlled trial that making an x-ray before the surgery improves outcomes. But that's often now the mandate or the requirements or that the double standard, I would like to say, that's put forth in the diagnostic field. And it ignores that for many other diagnostic procedures, histology and Ki-67, etc., there are no prospective randomized controlled trials that say if we do an H&E versus not doing an H&E, we have a better outcome. In principle, if somebody has a non-small cell lung cancer, an adeno or squamous cell carcinoma, we know those patients on average respond better to this. And if it's a small cell carcinoma, on average, they respond to something else. But there are no randomized controlled trials that show that when you do the testing, when you do the H&E, when you do the pathology, you have a better outcome. There is a lot of reasoning behind, and the reasoning is behind the Bradford-Hill criteria. And these are strengths of association, consistency, specificity, biological gradient, that's what we have at Sage Medic, plausibility, is it coherent, other analogies. And so that's actually the reason why the Cochrane collaboration, which is basically the cradle of evidence-based medicine, came out of von Archie Cochrane out of Oxford. He was a internist, a general practitioner. And so the Cochrane collaboration recognizes that and therefore usually evaluates diagnostics through test accuracy rather than RCTs, because the purpose of a diagnostic is to inform decisions, not really to produce outcomes. So it's actually reliability, applicability, impact on decisions rather than RCTs. And of course, that requires a certain amount of accuracy. And now I want to come back to the guidelines. These are things that are systematically developed recommendations by usually professional societies to help their colleagues, their clinicians, and patients making decisions about appropriate healthcare for their specific circumstances. So based on a review on available evidence and expert consensus. And I think that's kind of the important thing. It's not necessarily the best available evidence. What plays into there are many other things, and these are clinical, economic, practical realities of modern oncology care when we talk about NCCN. So it's not that it's anything that is in the guidelines is evidence that it works, and everything that is not in the guidelines is evidence that it doesn't work. That is actually not the case. One needs to understand that there are other dimensions that lead to those guidelines. And if you think about functional precision oncology tests, there have been many, many publications that have shown resistance and sensitivity predictions in the 80-90% range. This is a paper from Fulm that I recently digged out. So the evidence for taking a patient's specimen, and that's also what Cliff is, I believe, is going to do today. The evidence for taking a specimen, a fresh live tissue, in order to test it and see what could be the outcome, um, and that this correlates with patients' responses, the evidence is already pretty strong. And if you look at all the Bradford-Hill criteria, the evidence is stronger, as strong or stronger than other diagnostic assays. And that's also one of the reasons why when we developed our Sage Oncotest, where we take a fresh tissue specimen, break it up into fragments that maintain the tumor microenvironment and the cell-cell interactions, aggregate those within just one day, and then we can drug them to understand which drugs can actually really kill the tumor. We have here dose response curves. If it can't kill the tumor, even at doses that a patient that goes beyond what a patient can tolerate, then we know with high certainty this would only do more harm for this individual patient. And if we can kill it, then it's actually very, very promising. And one of the special other advantages besides the tumor microenvironment and having this in a very physiological replication is that we are not only looking at cytotoxic drugs, because there are a limited number of drugs that kill the tumor relatively quickly, but there are other drugs where the cell kill effect takes weeks or months, and it goes often through cell cycle inhibition, and it may also lead to just to a cytostatic effect, so that there is a prolonged disease-free survival or a progression-free survival. And that is basically anti-proliferation, which is another technology or an additional technology we developed and which is now has been patented last year. And we sometimes see that even at very low concentrations, certain drugs can actually have growth function, anti-proliferative effects. So it stops the cancer growth and can actually significantly increase progression-free survival. And it can be done because it's a pan-cancer test for a wide range of tumors. And we have started to do this and offer this to patients last year. And you can see here how different the spectrum is on cytotoxic effects and here anti-proliferative effects. And so that gives an insight for a oncologist and for the patient, which of the therapies are most likely to be most effective. If we look here down here at 5-FU, has no cytotoxicity, so the cell basically wouldn't change in any manner, except that it wouldn't really continue to divide. And if you look up here in 5-FU, it's actually relatively high up here. So the cell could actually go into a dormant state and basically do almost nothing and not change. And we would see that because we have a cytotoxic and an anti-proliferation assay. And we actually have also shown that this is often maintained even after the patient has received a certain therapy. So I don't want to belabor the point too long. In principle, if the standard of care is basically the minimum requirement that an oncologist or that a medical professional has to meet to make sure the patient is getting appropriate care. And I believe that these guidelines have done a great service to lift the standard of care for many people in the United States and worldwide. And yet, they are also used by insurance companies while this should be the bottom, they're also used to be the ceiling of what's covered, and also where the oncologist actually and to limiting the space where the oncologist can practice. And so if this therapy is not effective, if standard of care is not working, it's important that one is able, or for those who want to and have the energy to go beyond standard of care, because very often there is much more that can be done. And so I just wanted to clarify that standard of care is not necessarily evidence-based medicine. It tries to be, but there are many things that are different. And then guidelines are influenced by evidence, but also other factors. And understandably, standard of care is not necessarily the best possible care.
Thanks, Chris. And that's a good segue then to hand off to Cliff, because what's best may not be the standard of care because the standard of care is based on population averages. And if you go to N of one to a personalized solution, you may get something better. You may also get something better if there's something that's new that hasn't yet been reflected in the consensus. It hasn't been widely adopted. It hasn't been widely shared in the standard of care. And so there's this zone where what's best may not be the standard of care as well. So, Cliff, with that, I'll turn it over to you.
Thank you, Brad. Thanks, Chris. That's very, very helpful and very clear. So I'm going to do 4 slides here. So let's take about 10 minutes. Starting with the slide that was distributed, I think, as part of the webinar, that shows graphically a little bit what Chris was talking about. That at the lower left, what we see as standard of care that is supported by the evidence with a high degree of certainty and supported by consensus of oncology professionals with a high degree of agreement. And then at the upper right of this slide, which is labeled chaos, this is when you move away from certainty to uncertainty, you move away from consensus. But in between is a really interesting area because beyond standard of care, there are things that are still strongly evidence support. And smart people may agree to disagree about whether they mean consensus or make consensus. But some smart people like Chris and I think it certainly is supported. So we're kind of operating in that red square. You are here. And how do we operate there ethically and effectively to give cancer patients better treatments? So that's what I'm going to drill in and talk about. So as Chris noted, these drug sensitivity tests are really interesting. And I would say they're actually at Cancer Commons where we have 2 new resources to work with. The first new resource we have to work with is off-guideline drugs, and are not exactly new, but people aren't using these very much. And this is kind of a useful description of off-guideline drugs. If you look at this on the left side, that little diagram, what you see is that 2-dimensional chart. On the horizontal axis, you see the 67 NCCN cancers, and on the vertical axis, the 300 plus FDA-approved drugs. The number's about 330 right now. And I recently went into the NCCN guidelines and I counted drugs. It's like how many drugs are approved for each one of the NCCN cancers? And it turns out breast cancer has the most approved drugs with 61. I'd expect that to be non-small cell, but there are only 52 in non-small cell. And you go to the cancer with the least drugs, it's pancreatic cancer. Again, you'd expect that to be GBM, but NCCN combines all the CNS diseases into one. So there are actually 21 CNS cancers. So panc has the fewest drugs. But all of the other cancers fall between 61 and 15. And I've just sorted the cancers here on the horizontal axis by how many drugs are in the NCCN guidelines for each cancer. And when you put it on a chart like this, it sort of jumps out at you that most cancer drugs are not available to most cancer patients. In fact, about 90% of all cancer drugs are unavailable to any given cancer patient. And it's not because we know they don't work. It's simply because nobody's run a clinical trial to prove that the drug does work in the population sense across that particular cancer. And the reason for that is economics, right? To run a clinical trial is very expensive, $20 to $100 million. And if it's a small patient population, like all the rare cancers, or if it's just a population that no drug companies ever said we're going after this, you simply don't have the matching between all of these FDA-approved cancer drugs and all of the cancers. So this is an enormously underutilized resource. And back of the envelope calculations, hard to do this exactly, but the amount of money that we as a society spent to get these 330 FDA-approved drugs is about $1 trillion, okay? And 90% of them sit there idly, unused. That's not good, right? And then because we don't have the clinical trials to match drugs to cancers, we need something else. And that something else is drug sensitivity testing. As Chris said, the evidence for these drug sensitivity tests is growing. It's pretty good. His comment is it's even better than most other diagnostic tests. It's not widely accepted in the community, but Chris and I and many others feel like this is a juggernaut. This is going to happen. I just had a recent conversation with Keith Flaherty, the new president of AACR. And I said, hey, Keith, my view is that 20 years from now, we're not going to give cancer drugs to cancer patients based on population testing. We're going to do it based on drug sensitivity testing. And Keith said, I agree 100%. So there's an understanding that this is where cancer medicine is going, and also an understanding it's going to take a while to get there because everything changes slowly in cancer. But with these two new resources, we can do some dramatic new things for cancer patients and getting them, right drug to the right patient at the right time. The mantra of personalized oncology, we can actually deliver that. So let me show you how Cancer Commons is doing that with a clever study design. So this is the workflow through our new clinical study. The study launched about 3 weeks ago. We're just beginning to enroll patients now. And you'll notice the kind of the two swim lanes in this diagram. The first one being standard medical practice and the second one being our clinical study. Cancer Commons is, we are not oncologists. We're a bunch of PhDs who are really good at data analysis and really good at decision support. Okay. And that's the resource that we're bringing. So let me just kind of walk you through the workflow here. And then I'll do a quick example on the next slide, and then I'll be done and open for questions. So we start with diagnostic testing. And we actually do two forms of diagnostic testing. My last two companies, we do genomic testing and we do drug sensitivity testing. Okay. And so what we have, our patient intake is we need, whenever possible, we need the results of both of those tests. So then what the Cancer Commons team does, which is 5 PhDs in genetics and molecular biology, is we go through those test results and we go into the scientific literature and we say, hey, what is the evidence, both direct patient testing and scientific literature, that argues for, that scientifically justifies the use of an off-guideline cancer drug for this cancer patient? And we take a lot of time and energy to write up a report as convincing as we can make the report. And by the way, if we don't find anything, we stop. I mean, we're not trying to get a patient into the study. We're trying to get the patient into effective treatment. Okay. When we have this evidence report, then we have to do two things. And in the description that Brad put out, the last two bullet items in his agenda were challenges and overcoming them. Well, here are the challenges. The first thing you have to do with that report is convince the oncologist to treat. And as Chris pointed out, there are a lot of barriers for oncologists to treat off guideline. There are institutional barriers, there are financial barriers, and there are legal barriers. But there are also a group of early adopter oncologists who've come out of medical school and gone into clinical practice and realize a lot of their late-stage patients are dying unnecessarily, and they're willing to be innovative. And that's our oncologist. So we're not trying to talk every oncologist into doing this. We won't succeed at that. What we're trying to do is find the oncologists who are predisposed and inclined to going off guideline in order to help their patients. So we first, find that oncologist, have an oncologist that wants to work with us. Then the hard part happens, which is we have to go to the insurance company and convince them to reimburse off guideline. And one of the things that's done for us is to find our patient population. Our patient population is that patient population that can be categorized as having a medical necessity. Right? They've tried everything, they failed everything, and their best choice right now is hospice and death. And compared to that best choice, an off-guideline drug might be better. So we do our best to convince the insurance company to reimburse. And if we win those two arguments, the oncologist to treat and the insurance company to pay, then the oncologist treats the patient. And once again, we're in the medicine swim lane. We don't do any of that. We say all of our oncologist partners unilaterally make every treatment decision. We're just a decision support team. And when the oncologist treats with an off-guideline drug, we get the data. So if you think about what we get from a patient, we get their diagnostic test, we get their treatment activity, action, whatever the oncologist treated with, and then we get the result of that treatment. And what we can do from that is calculate the predictive accuracy of the test. And that's actually the primary endpoint of this clinical study, is to calculate the predictive accuracy of drug sensitivity tests to help the community understand that these drug sensitivity tests are quite good. Now, Chris's company and my old company and Carla's company and Hugo's company, we've all done, clinical testing ourselves, but it's always done by the vendor. And it's always kind of viewed askance, because the vendor has a financial interest in the test working. Cancer Commons is able to do this, completely with no biases at all, and be able to provide a 501c3 platform to evaluate these drug sensitivity tests and hopefully find the tests that work the best. And we expect to find some tests that work better for some cancers or some drugs, but this data will all be published, once we have enough data to be worth publishing. And then the final thing I'll say is, let me give you an example of this. And this is a made up example. This was a actually a mashup of two patients that came through Cancer Commons, but to give you an idea of what really works. So this is an example of that scientific evidence report we use for the oncologist and we use for the insurance company. And in this example, what we started with was a stage 4 pancreatic patient who had an interesting mutation, a RAF1 mutation. It was a very rare mutation. There is no targeted therapy for RAF1. There are not enough of these mutations to justify the economics of running a study to try to, doing this work to try to find a targeted therapy. But it was interesting they had the RAF1 mutation. We then run the patient through the Trevera test, run them through a panel of 20 different drugs, one of which is trametinib, which is a MEK inhibitor. And son of a gun, for whatever reason, this patient's live cells in the Trevera lab responded well to trametinib. And it's like, okay, fascinating. It's a MEK inhibitor. Patient doesn't have a MEK mutation at all. So then our team goes into the scientific literature and sort of, lo and behold, there is a broad scientific literature that says, the MEK mutation and the RAF1 mutation are really close to each other. They're in the same cancer pathway. It's like, how interesting is that? So we write the whole thing up. We say we have strong reason to believe that trametinib is going to work for this panc patient, even though trametinib is not on guideline for pancreatic patients. But we have a really good reason to believe it's going to work. We take that to the oncologist, we take that to the insurance company, and if we win those two arguments, the patient gets trametinib. Maybe they respond to it, maybe they don't, but the patient gets trametinib, and then we have another data point in our clinical study for determining are these drug sensitivity tests as good as we hope they are for selecting cancer drugs for cancer patients. So that's what we're doing at Cancer Commons, sort of a cleverly designed observational study where what we're really doing is providing decision support for the oncologist and decision support for the insurance company to provide off-guideline drugs to cancer patients who are out of options. And with that, I'll pause and hand it back to Brad.
Thanks, Cliff. As usual, we will take questions from the chat. I'll moderate. I'll feed them to Chris and Cliff from the chat, and there are already some comments there. And as well, people can raise their hand, and I'll call on you, and you can raise your question verbally. I'll take license to ask one quickly here, Cliff. There have already been questions, as both of you know well, and it's been mentioned. Functional testing requires fresh tissue, and it's often the case that people don't have easy access to fresh tissue, as Russ mentioned. It's kind of a catch-22, like if you're in remission, you don't have any, and so that you don't do it. So, the bad news might be your cancer's coming back. Now you have something that can be biopsied, but often that tissue is close to some place that's hard to access. It might be near some internal organ, so it's difficult to biopsy and get access to that fresh tissue. So can you speak to that challenge, like getting fresh tissue to feed the functional testing? And also, we had a presentation on single cell RNA sequencing. We've had this hackathon where there was extensive RNA sequencing, which would also identify treatment options and maybe treatment strategies. That would be another form of input besides functional testing, and I just think those will increase over time. Liquid biopsies similarly could be giving information that would indicate a possibly useful treatment option, and yet might not be part of the standard of care and would lead you towards off-label. So maybe Cliff and then Chris, if you could just both respond to that.
Yeah, first, the structure of our study is that it's a study that's made of multiple arms. And unlike a lot of studies where the arms are cancers, in our study, the arms are tests. So we have a SAGE oncotest arm of the study. We have a Trevera RTS arm of the study. And what we are looking to do is add arms to this study of tests in other modalities. So an RNA-seq test would become an arm of the study. And any kind of a liquid biopsy test, people growing organoids from CTCs, an arm of the study. So we are delighted and rooting for as many different arms of this study as possible. Getting a lot of patients into each arm is going to take us time, of course, but that's fine. We have time. The biopsy question is real. And there are a lot of patients who don't qualify for any kind of functional testing because they can't tolerate a biopsy. But there are a lot of patients who do qualify, in particular patients who are metastasized, they have multiple nodules, and with a number 17 needle, an oncologist can, punch in and to the nodule and get a live sample and send it off to a lab for testing. That is the functional testing patient. The other functional testing patient is a patient with an ascites or a pleural effusion. Lungs typically ascites and GI typically pleural effusions. Those turn out to be terrific sample types for functional testing. A lot of patients have catheters and they're draining those things for comfort. And so getting access to those samples is great. So the functional testing, the tissue-based functional testing companies do require a patient to have a tissue-based biopsy or a liquid biopsy. The other issue that comes up, which I'll speak to, is who pays for it, right? And at Trevera, it turned out we had terrific results when a patient was in a position to get a new biopsy, to send them back to their oncologist and say, write an order for another genomic test, which is reimbursed. And oh, by the way, when they're in doing the biopsy for the genomic test, send us half the tissue. And that worked incredibly well for many patients. So an imperfect answer, but for a lot of patients, we can get tissue biopsies. And as these new generation of tests come on, and particularly the LBX, the liquid biopsy test, we're thrilled and delighted if somebody can come up with an effective test from a liquid biopsy to do therapy guidance. Chris?
Thanks, Cliff. Chris, did you have something to say to that about getting access to material?
Sure. And by the way, Cliff, very well phrased, very, very well said. And I can only agree with you that yes, the best way to get the tissue is when tissue is taken for pathology anyway,
Yeah.
and and that can be arranged because if a patient is not responding to the therapy or stops responding to the therapy, it's not unusual that a second biopsy is done. Sometimes biopsies are done repeatedly, two, three, four times over the course of the disease. So it's not that, oh, the patient already had a biopsy a year ago, so we don't have access to live tissue. No, usually in a breast cancer patient, a liver biopsy can be done, and we can test dozens of drugs based on core needle biopsies, and ideally also in situations where the patient is undergoing another, let's say, debulking surgery, and which is not uncommon. If you think about ovarian, if you think about colorectal, if you think about glioblastoma, roughly 20-30% of patients actually undergo another surgery, and that's a real source for tissue. And then to close this off with ascites and pleural effusions, we have been very, very lucky with ascites. We have tons of tissue in there and have really been able to create beautiful dose response curves and saw very, very clear signals. So that's a very good opportunity. And then the part with the pleural effusions, about half of, for example, the lung cancer patients have pleural effusions. Not all of them are malignant. About probably 60% of those are malignant. So one doesn't know what's coming out of this, but it's not a reason not to try for it. The disadvantage with the pleural effusions or the ascites is those patients usually are so late in their disease that most oncologists then say, well, there's nothing I can do for you anymore, and I think you should go to hospice. And I think that's actually what patients then needs to know that, well, there may be something we can do. And there is no reason to give up. And there are enough examples for patients who had ascites and ultimately, when getting the right treatment, got back on the track and got another couple of years. So getting the specimen and pushing for it. So because what's the other alternative? Go on a clinical trial. But going on a clinical trial does also have a very low chance of success. And in a way, doing the functional testing before going on a clinical trial, or perhaps even to direct towards the clinical trial, is the right way to go. So instead of saying, well, we may have difficulties to get access to the tissue, why don't I look what clinical trials we have? It would actually be better is let's get the functional profiling done first, and then let's see whether some of the FDA-approved drugs may be good, or whether there could be some of the clinical trials you may be eligible for, whether you would actually be sensitive for one of those clinical trials that would be good for the clinical trial and it would be good for you.
Just a quick question, staying with this, and then we'll move on. Susan Harrell asks, for live tissue, have you heard of Kernus? And then I think you've covered what some of the options are that people have, but have you heard of Kernus?
I have not.
I just
Is
bring
there
it
a
up. It's a
website?
yes, they have a website. They're very new, but it's a way to sort of do kind of personal biobanking or send live tissue. But I'm just curious, like, is that a list of, are there other companies doing that? Do hospitals do that? What options do folks have?
Yeah, in principle, the NCCN cancer centers don't do live tissue. They have huge tumor banks, all either frozen, fresh frozen, or paraffin fixed, and they sell them to pharma companies and make a lot of money on this. But live tissue usually not. These are usually individual research projects. But Cliff, probably you also have some ideas. There are some companies that are storing live tissue. What I don't know is what the recovery rate is. One can use cryoprotectants so that the recovery rate of viable tissue is higher, but the best way is really to get it live.
Yeah, back at Trevera, we did a lot of testing on fresh frozen, cryopreserved with Mehmet Toner at Harvard, who's been a big guy in the field, and our success rates were shockingly low. And in fact, the whole Trevera test is it's a 48-hour turnaround test, because 24 hours of it is at FedEx shipping, and from the time we get this live cells out of the FedEx package to the time we've done all of our testing is another 24 hours. And we have a standing rule that if the FedEx package sits in Memphis, for 48 hours because it's snowing, we don't even test it. These cancer cells die so fast and they change so quickly under pressures of media that they very quickly become unrepresentative of the patient's tumor. So cancer cells are really, really tough to deal with. And Chris has lab techniques and Trevera has lab techniques and all the companies have lab techniques for kind of preserving the authenticity of the cancer cells. And anybody who's doing this for other purposes probably is not kind of working toward that end.
Okay. I just call in Hillary, who has her hand raised.
Oh, thank you very much. I'd like to lend my supportive comments while we are still being recorded, because this recording will reach a much larger audience than those who are in attendance. So, as a patient and as a healthcare provider and administrator, there is no standard of care for rare cancers with poor prognosis. Rare cancers with very limited disease-free progression and short overall survival obviously do not respond to standard of care. So by not applying this type of technology, which is available and amazingly, it is quite cost effective, by not applying that, in my opinion, is becoming medical malpractice. So I would like to see this technology applied broadly for rare cancers with poor prognoses. And additionally, as a healthcare administrator with my money side cap on, this will save a lot of money in the long run. Look at all of the side effects that we have to pay for, that insurance has to pay for from the toxicity of the standard of care therapeutics that are applied towards these patient populations. So kudos to you. I'm enjoying your presentation, and I hope this reaches a broad audience. Thank you.
Thank you, Hillary.
Thanks, Hillary. Russ, you had a number of questions some of which may have been answered. Russ, do you want to just come forward and
Yeah,
voice
sure.
whatever is most top of mind for you?
Sure. Let's say I've examined the evidence-based medicine and I've made a conclusion based on my calculations and maybe talking to certain oncologists or researchers, and I came to a conclusion that I want to try some non-guideline therapy. If most oncologists, standard oncologists will not go for that, insurance covered practitioners will not go for that, how do I get it done? And let's say, in addition, let's say finances are an issue. I can afford the therapy and I can afford the drugs for it, but I can't afford $5,000, $10,000 to pony up to put a stamp of approval on it. I want to do this, but I want to do it practically. What do I do then?
So,
Is there out for me? Could I go to Cancer Commons?
there are two ways. The standard way to do this is, or a conventional safe way, is to say, okay, this is part of a clinical trial. Whenever things are part of the clinical trial approved by an IRB, Institutional Review Board, then basically the oncologist is off the hook in terms of the liability. The oncologist
Okay,
still
let me
needs to be
interrupt you just one
comfortable with the
second, Chris.
approach.
Dr. Apfel, can I interrupt you for just one second? Let's say it's not part of a clinical trial. Let's say, for example, me is hormone sensitive prostate cancer, bipolar androgen therapy, no clinical trial. So what do I do then? If it's part of a clinical trial, I understand you can go through an oncologist, you can say it's part of a clinical trial, and you can get it approved. But if it's not part of a clinical trial, what would I do in that case?
So, so, so I'm working with a physician who has her own IRB, and we can go through her and see whether we can get an IRB approval for that within a week. It would be an interesting
Okay.
test to explore.
Okay.
Um, and yeah, I think
So
at ultimately that's kind of what is it, the checkbox that would reassure would take most of the reservation or concerns of an oncologist off the table.
okay, so then my private oncologist, my personal oncologist would authorize or guide the therapy, but then would be after the IRB approves it. Is that potentially how you would see it
Right.
going?
So it's actually the IRB would approve this. One needs to have a PI for the IRB. So if, for example, at Cancer Commons, Cliff and his other partners are the co-PIs on that study. If this was part of Cliff's study, then they would be the PIs. They would come up with the regimen, and then they would uh, hand this to your oncologist and says, this is what we think is reasonable. This is what the patient would like to have done. Um, how would you be comfortable with that?
Yeah, and let me jump in there.
Does
Our study is not an interventional clinical study where it's our oncologist doing the treatment, right? All we're doing is providing decision support to your oncologist. But let me share with you a story from Trevera. And the story from Trevera is when we started running our drug sensitivity tests and needing biopsies for to do that. Trevera, and myself and Dennis Watson at Trevera, the head of sales, would reach out to oncologists and explain what we were doing and tell them, how innovative it was. And we did that for many months, and our success rate was about 10%. And largely because oncologists, they don't want to go off guideline. It's difficult for them, and they're busy people. A typical oncologist in the US sees 300 cancer patients a month. And just taking our phone call is devastating to them because that means that's a patient they're not treating, right? So Dennis came up with a brilliant idea, and he said, well, we're just going to teach our patients to be our marketing arm, which we did. And so we gave them all the literature, we gave them the pictures, and we gave them the text, and we gave them the talk track and the emails and like that. And once again, I will say this is works in the hands of late stage patients who are out of options, right? That's our patient population. And we had our patients go into their oncologist's office and say, I want to try this new thing because hospice and death is not my first choice. And our success rate went from 10% to 70%. And I think that we've learned the power of patients in advocating for themselves as opposed to the power of the vendor to try to talk the oncologist into doing something new. And we live by that now. Now, the number of patients who are able to do that, Russ, you're clearly one of them. I talk to oncologists. something like 10 to 20% of patients in the US are activist patients and can advocate to their oncologist. And for now, that's good enough. This is the Jeff Moore crossing the chasm model. We got to start with the early adopters, the early adopter patients and the early adopter oncologists in order to get this flywheel going. Because at some point, to Hillary's point, it's going to be obvious to everybody that this is a really good approach to picking cancer drugs for cancer patients compared to population averages. So let's, start small, start with early adopters. And Russ, the other thing is a year from now, I hope I can answer your question better by saying your oncologist just won't do it. Doesn't make them a bad person. They probably have institutional constraints where they just can't do it. Here's our list of 50 oncologists, 3 in every major city, and just reach out to them and they'll take over your treatment and provide you the drugs that you need because they're willing to do it because they've decided that that's the best path of patient care.
Cliff, you're saying within a year, maybe you would have that list?
I sure hope so.
Possibly. I mean, no guarantees. I understand, but
Yeah.
you're
Yeah,
working
but
on it. That'd be awesome.
yeah,
That'd be
I
great.
really
It'd
do
help
hope
a lot
so.
of people, I think.
We hope to have oncologists, and now again, it's every major city in the U.S. and 85% of all patients are treated in community hospitals. It's still a very unsatisfying answer, but it's maybe better than nothing.
It's better than nothing. Yes. Good start. Thank you.
Thank you. I think you've just answered Susan Horrell's question about how patients can find those innovative, forward-thinking oncologists. Maybe you'll come up with places you can steer them towards.
Yeah, eventually we'll be able to help them. We're just, we launched the study weeks ago. We're just at the early stage of that. And again, our job isn't educating oncologists, it's finding them. It's finding the ones that are predisposed because anybody who is predisposed against this, this is Thomas Kuhn's The Structure of Scientific Revolutions. We are driving a scientific revolution here. And as Thomas Kuhn writes well, the only way to succeed at that is to have all of the existing scientists die because they're not going to go along with it. There are a handful of the early adopters that will. The late majority, we have to wait for them to die. That is the time frame of the adoption of this technology to be standard practice in oncology.
Next up is a question from Ari, which you may have covered as well, but it's getting the diagnostic tests at the start if they're not part of the standards.
How to pay for it in particular?
No, just how to, I guess, to be aware. Patients have to be aware that there's such a thing as functional testing, and then they have to advocate. I think you've covered
Right.
some of this, but just to,
Yeah, unfortunately, the functional testing community right now is tiny. There may be 10 companies that do, any reasonable version of it. So there's no big marketing push behind it. It is really up to individual cancer patients to find us. We don't have the marketing strength to reach out and do any kind of a national campaign to find them. But when they do find us, and in particular, if they find us and want to come into the Cancer Commons study, we do provide all the testing for free. So, that is at least helpful to them. But the marketing problem, it remains a significant problem, and with very little funding to educate the patient community that this exists.
It's amazing. Really, the question was around bottlenecks, and would you say that is sort of one of the biggest bottlenecks to scaling this up?
I don't think we're ready to scale it up. Again, I think it's an early adopter model that is going to, through word of mouth, going to kind of scale itself. I mean, I'm a lot more concerned about too many patients than not enough right now. This community kind of illustrates it. When this thing starts, it's going to go like wildfire. So, right now we're the best kept secret in town, and I don't think it's going to last very long.
Sandra asks, how do patients enroll? Upfront payment? Is this service only offered in the US?
How do they enroll upfront payment? Everything Cancer Commons has ever done is free. Everything Cancer Commons will ever do in the future is free. We are a patient support organization, and we will never charge a patient a nickel for anything. Enrolling is go to the Cancer Commons website, fill out the registration page, say you're interested in our clinical study, and a patient navigator will contact you within 48 hours.
Jamie Barber
Yeah, and I
asks,
have
oh,
so
go ahead.
Sage Medic has now hired a oncology nurse, and we can actually also take samples from overseas because we have developed a shipment technology that enables us to get actually identical results even 3 days after explantation.
Jamie Barber asks, is it worth having patients enroll who have had RNA-seq done but no treatment have been identified with the company's algorithm? Are there additional things that can be pulled out from the data that might be missed by one company?
I have a strong opinion on that. Chris, you want to go first?
So what we always are looking for, we are looking for the histology and for the RNA, DNA, any other omics information we have. We look at this very carefully. We use also some AI and ask ourselves, so what are the drugs that could actually work based on those mutations? And we will add those to our testing panel to maximize the chance that we are finding a therapy that could work for that individual patient.
And in my view, I know we're at top of the hour. I'll make this quick. At PMWC, the Personal Medicine World Conference last year, there was a nice talk given by a group called ATIA, which is doing foundational models of biology and cancer. And the gentleman on the stage, and this is not proven scientifically or anything, but he did a poll of the audience. He said, "What percentage of cancer biology do you think we understand?" And his conclusion was, what we understand is about 5%. I think that number is probably high. My view of that number is more like 2%. Okay. But if RNA-seq is in that 5%, okay? All of genomics is in that 5%. What little we understand about proteomics is in that 5%. When you apply a cancer drug to a live cancer cell, what percentage of cancer medicine is that live cell using to respond to that drug? 100%. Okay? So what we get from live cell testing is a readout of everything we know about cancer medicine and a readout of everything we don't know about cancer medicine. Live cell testing is the gold standard. I'm hoping against hope that an RNA-seq test that's well within that 5% can pick the right therapies. That's a great thing for patients. I'm hoping against hope that the next targeted therapy is Gleevec, that works for, 95% of CML patients. It's unlikely because cancer medicine is so complicated. And interrogating the cell rather than interrogating one of the millions of molecules that surrounds the cell is more likely to give us the right answer.
Okay, Cliff, you pointed out, and I should be the timekeeper, we're at the hour. There are half a dozen more questions here. Chris and Cliff, should we wrap up? Because I want to give you time to have a closing statement.
I can stay on, but if people want to take questions, that's fine. But anyone who needs to drop, please drop. We won't be insulted.
How about you, Chris? Do you have another 5 or 10 minutes?
I do, and if you want to have a closing statement, I think it's hard to top how Cliff actually has phrased this. I think it was very well understood. It's very clear that with the multi-omics approach, it only captures a small fraction of what's going on in the cell. And even with AI, it's unlikely that it will give us a complete prediction on to which drug a cell will respond. And the best way to understand whether a tumor will respond to a therapy is basically exposing the tumor to the therapy. And that's what SAGE is doing. That's what Cliff's Cancer Commons Initiative study is doing, is really testing the live tumor. And only by testing the live tumor, you have an integrated approach to understand which of the therapies can potentially work. And so, as you said, Cliff, it's both the information we know, the pathways we know, and it also tests the pathways we don't know, which is actually the majority of pathways.
Okay, let me just ask a couple more questions from the chat, and then I'll ask you each to sort of formulate a closing message, your summary that you want to leave us with. Susan Harrell asks, how controversial are these treatment conclusions? That's the wrong word, but if you get 10 oncologists in a room with these results, will they come to 10 different conclusions? Or is there such a high degree of evidence here that one should have a lot of confidence with these conclusions?
This is what the Cancer Commons study is attempting to do. As Chris, eloquently described, the the metric for judging a diagnostic test is not a randomized controlled trial. It's the accuracy of the test, and it's specifically the predictive accuracy that, a test that says, yes, give them this drug, it's going to work. No, don't give them this drug that isn't going to work. When what we're generating is a database that literally takes the number of correct predictions, divides it by the number of total predictions, and says that's the predictive accuracy of the test. That kind of data, at scale, not 10 patients, but hundreds of patients and ultimately thousands of patients, is completely convincing to all of the reasonable oncologists I've spoken to. So they're not looking for something magical we can't do. They're just looking for really good clinical data that shows that these tests do what they say they can do. So I think we're short of data and we're on the track to getting it.
That's a pretty good closing statement. Uh, how can patients tell which companies are reasonable or trustworthy?
Calculate their predictive accuracy and publish it.
And well, I would also say, look at the technology. I mean, we do know that the tumor biology is not just an individual cell, it's often also the tumor microenvironment. That's one part. And then there are most other assays are looking just at cell death. And there are many drugs that actually work through anti-proliferation. So this is the Sage Oncotest can also measure growth inhibition. And so look into what the test really does. Get a sample report of the test, so that you can compare what does the print out, what's the result, what will you get, and how might this help you in in your in your further pathway.
I'm not sure if I asked Jamie Barber's question here, and this will be the last one. Is it worth having patients enroll who have had RNA-seq done, but no treatments have been identified with the company's algorithms? Are there additional things that can be pulled out from the data that might be missed by one company?
Yes. Again, cell testing tests not only everything that genomics and proteomics and transcriptomics and epigenomics can test, it tests all the stuff we don't know. So yes, it's absolutely worth getting a live cell test, even if all other modalities of testing have shown nothing.
All right. So, each of you just could you leave with a closing statement? Anything, key messages you want to make sure that we've taken away from the discussion today? Chris and then Cliff. Chris.
I would say if you want to make, if you need to make treatment decisions for your next treatment, you want to have your tumor tested first, irrespective of whether it is standard of care, whether it is an FDA-approved drug that is approved for other tumors, or whether it is a drug from a clinical trial. You want to have your tumor tested first before you go forward. So don't fly blindly.
Cliff.
And let me close with it with a Cancer Commons request. At Cancer Commons, we just launched this study, and we're doing it all on philanthropic money. Cancer Commons, doesn't have any commercial revenue. Actually, there's no government revenue, has no venture revenue, no venture backing of any kind. I have been raising venture money for the last 35 years of my life. I'm really good at it, and I raised $250 million for Complete Genomics, and I have looked long and hard for how to raise venture money from my very close friends in the diagnostics venture community to service these patients. And it's impossible. Okay. Late stage cancer patients, they don't buy expensive drugs, they don't buy expensive radiation, and they don't buy expensive surgery. There is no business model for serving the 600,000 cancer patients who die every year from cancer and haven't tried everything yet. The only way we can do that is philanthropic support. Government should intervene. Our government right now is kind of in a mess. That's not one of our financing options. So we at Cancer Commons are starting a massive initiative to raise additional philanthropic funding to accelerate the process of bringing this technology to market. And I'm going to reach out to each and every one of you with Brad's permission, not for your money. That's not what there are going to be some rich people to give us the money. What I need from you and each of you is your letter of support. I want you to write a letter of support to say, we think what Cancer Commons is doing with Chris, with Trevera, with Carla, with all these companies is a wonderful thing. And we support their activity. And we want you, cancer survivors with $1 billion in the bank. We want you to finance this to make it go faster. So I will say thank you in advance for any letters of support that you guys can provide, and I will use them well in order to generate the kind of funding that we're going to need to bring this into commercial practice.